There we go. The recording is on. And yes, today, March 4th, it's a month since we started this training. Can you believe it? Time really flies. And today we have Bitten Jonsson from Sweden, a registered nurse and addiction professional. This is Cynthia. I don't know why she's not. Oh, I need to take pauses here. Okay, we're on recording mode again, so it's take two. Introducing Bitten Jonsson today, who is a good friend and a colleague from Sweden, registered nurse, and one of the addiction specialists, in my opinion, and in the world. And very, very honored to have friendship with Bitten and also to be a colleague of her, and first and foremost to have her on board with us in this training. And I must tell you that it's pretty much for her, as for many others, that we're doing this today with this training, because she was such a great supporter for me to and for us to really do this. So I want just to introduce Bitten, and she's gonna tell us all about what she's gonna be doing. She's gonna be doing, actually, I'm just gonna say it in a few words, 2 different lectures today. One is on us screening and assessing and mapping and all of that, and the other one is on biochemical repair, which is, to me, an extremely interesting addition to understanding what to do with and how to help a lot of people with different problems concerning addiction. So, Bitten, here you go.
Thank you. This is a dream come true. I remember Esther and I speaking about, doing this kind of international training some years ago. And I thought, well, it's going to take 30 years or something, with the pace things is going in Sweden. That's what I thought. But, Esther pulled it through, and I love it. So, as usual, I have always too much material, because I'm usually, when I'm teaching or, doing workshops for clients, I talk 8 hours a day, 4 days in a row. So to ask me to talk 1 hour, that's very difficult. So I'm going to practice that today. So when the hour is up, we're done. And if you need more, you have to contact me or something. I don't know, some of you might have gone through the material I sent out. So I thought I'd just ask a quick question. Do you have any questions about the material? Is there something special you have been thinking about that before I go into the lecture? Nope. Everybody perfectly understand what that is all about. Great. Okay.
Actually, I didn't get the materials.
It's in the Dropbox.
Oh, okay. All right. There.
Okay. Well, Sandra,
I didn't either.
Sandra,
sorry.
I sent it by WeTransfer, and it's also in Dropbox.
When did you send the WeTransfer one?
Early this last week.
Thursday sometime, I think. But Sandra, when you go in the Dropbox and you look through my material, some of the papers I put there, if you have any questions, please mail me.
Okay. And Esther, if you don't mind sending the WeTransfer again, I missed it. Because I'm very diligent about downloading everything. So if you don't mind resending.
Absolutely, and I'm sorry if I missed you out of the loop for that, Sandra. I'm really sorry about
I
that.
also didn't get it.
Yeah, me too, please. Yeah, I would appreciate if you can send it again, please.
Okay.
Sure.
I'll do it.
Okay. Okay, anyway, early 1990, I came back from US 1988, and my first contact with addiction medicine, as it's for me since I'm a nurse, was 1985, when I was forced into treatment for my alcoholism, which I hated every second of the first 2 weeks before the coin dropped. And I started understanding the disease concept and recovery. So I've been in recovery for my alcoholism since then, and it's 33 years ago since I met food addiction concept and started going to recovery. I haven't been drug-free, as I prefer to say drug-free instead of abstinent, and I come to that. For 23 years. I had lots of slips and lapses and relapses in the beginning. As I can see today, was learning experience. But I've been in the program anyway for more than 31 years, and I'm very grateful, extremely grateful. And I met Mary at a training class for Terence Gorski about 23 years ago, and that's how I ended up being with you guys today, to make a long story short. So anyway, and then I totally fell in love with addiction medicine, and I left nursing and just wanted to work with this, and I've done that for about 30 years almost. I've been working with addiction medicine both in US and here in Sweden. And in Sweden there were nothing, so I've developed the addiction treatment that I work on today by picking a lot of good heads all over the world, Esther's for instance, and others. And also, doing training in US mostly, because we don't have any good training over in Sweden. So, and what I see today is that still many people are, working with a psychosocial model. There's something in your childhood that makes you addicted, or it's because you don't have work, or because you're lonely, or because something you are using drugs. And that is not the way I'm trained. That is good, working with harmful use. Why do you overdo things? Why do you overeat? Why do you drink too much? Why do you? That's a very interesting question, and good to use when we work with harmful use and prevention, but not with addiction, because addiction is an acquired and primary illness. And that is my absolute firm belief. That doesn't mean that we dismiss any trauma or childhood problems or stressors or traumatic events during life that exaggerates addiction, but it's not the cause of addiction. That is very, very important for me to keep those two apart. Because if we will heal a person and do recovery, we have to take away the drug. And we have to understand that it is a chronic illness. You can't put the drug back. So that is the important thing with working with the addiction model to me. And what I saw was that as being a nurse, you are very into trying to understand what is making this client sick. We need to take blood tests, we need to do x-ray, we need to do a lot of tests in order to be sure what is it we are treating. But with the addicts, which has a very low stigma in Sweden, nobody cared about that. So, well, I think you're an alcoholic, we throw you in here, but you can't be an alcoholic because your wife is still with you and you do have a job yet, so I don't think you're an alcoholic. And then people drank themselves to death because, of course, they were, but nobody saw it. And also in Sweden, there is a lot of opinions about what addiction is, and very few have insights. And I work hard to talk about the differences in having an opinion and having insights. So to me, it's very necessary and important to do and have some kind of evaluation model. What is it I'm working with? And I do make a big difference between social use, harmful use, and addiction. Those are the three terms that I use. And then there is a lot of, other kind of terminologies that people use, but I don't use them because I think it's just confusing. I think it's very simple to keep it 3 levels. Social users, they don't have a problem. They're not going to come looking for us. And then we have the harmful users. They can benefit many of the traditional models, like, getting a good cookbook, go to cooking lessons, read about health, read about nutrition, go to Weight Watchers. They can use those things. But an addict cannot use any of those tools. An addict needs professional training by a very well-educated professional in addiction model. So to me, that's important. And today we do have a much more complex picture than when I started out. You know, when I started out 1985, we had alcoholics and maybe some drug addicts. But nobody thought that alcoholics could have any other outlets from their illness. But today we live in, as I see it, an addictive society with lots of addictive things all around us. And we didn't have food the way we have it today in 1985. And today we talk about, you know, addiction interaction disorder, AID. And we also, when I assess a client, I ask questions to see if there are other outlets laying there, you know, something that could be an addiction in the future, some kind of obsessive behavior that they also do. I'm sure you all know that many of our clients are doing exercise obsessively or sometimes as an addiction. And what I learned in USA also was that addiction is the big imitator. You know, it could look like a lot of other illnesses. So if you don't understand to ask the right question to a client, like if somebody come in for a broken leg 3 times, I mean, you should ask them about their alcohol behavior. But people don't. They don't think that it could be an addiction behind. And if you're an addiction counselor, you're trained in thinking that you should always look for addiction until you know it isn't. Because if it isn't, there's something easier to treat. But this is the picture we see so that today, you know, that we have clients that have a lot of outlets for their addictive personality. And as you can think, you know, I misspelled food, I see that there. Sugar and food is, of course, the biggest one. There is no doubt in my mind that that is the most biggest addiction we have today. And then alcohol. But, you know, gambling is coming huge in Sweden. Opiates is huge, as I see it in US, and it's coming in Sweden too. But you do have a lot of things that could be addictive. We live in an addictive society. So that's why we need to look at addiction interaction disorder. And it is about the brain, not only the drug. So today, when we work with food addicts, we have to look at their drinking, if they're using subscription pills, if they have other obsessive behaviors that could be an addiction. Because if we do not address that and start treating the addicted brain, you know, we will not get a full recovery in the long run. The client will just chase around that circle and, you know, try other outlets all the time. And in a recent survey, I heard that they think that only 17% at most, and I think the number is lower actually. I would say 7-8 have only one outlet. And I count codependency as an outlet too. And that 80% of relapses are due to unknown outlets, i.e. the client has another outlet. When we take away one drug, they are using something else to keep their addictive process going. So that's very interesting numbers, I think. And of course, you all know the psychoactive substances. I don't really have to teach you that. I'm sure you all know that. And when we did a diagnostic assessment on 202 patients here in Sweden, you know, we did the 202 patients that were food addicts, and 74% of those were hidden alcoholics. they were not the classical alcoholic that you see that really drink a lot and drink often and have a lot of negative consequences. But if you look at the criteria in ICD-10, you could see that when they drank, even if it was 2 or 3 times a year, they did have pathological influences. So they were, according to the diagnostic criteria, alcoholics. And one of the things that I advised my clients, that I say very firmly, even if they never have had any problem with alcohol, alcohol in any way, shape, or form is not part of an abstinent food plan. So alcohol is gone, and also that they need to be very aware of other psychoactive substances, like if they're going into surgery or so forth. And actually I've seen clients relapse that got on painkillers, because of course that affected the reward system. So they got cravings for the food again and went back to food. So, and also we look at process addictions. Gambling is big in Sweden, sex and relationship, working, internet, exercise, debting, spending, codependency. And when you talk to researchers that sit in a little research room and only look at the brain, they say that all addictions act equally in the brain. So the brain doesn't differ between, you know, the kind of biochemical neurotransmitter happenings from gambling or sugar. You know, you get other physical consequences of sugar and flour, but, you know, in the reward system, the same thing is happening. Okay. Any questions so far? Well, holler if you have.
I had a question. You mentioned caffeine as a psychoactive substance. Can you talk a bit about that? We talked about caffeine last week, and I'm a little bit confused about, you know, should that be something a food addict up, or is it, yeah.
My experience is that once people are, so caffeine is affecting adrenaline. It's not really affecting, you know, dopamine, serotonin, and those neurotransmitters. So I'm a little bit hesitant to have it on, but it is on lists. If you look at other people's lists, you know, what is a psychoactive drug is on there. And of course, I mean, you could, as we talked about, I think Teresa said it very well, and also Vera, that you could be actually overdoing anything. I mean, water, you could drink too much water. So my experience is that it's something I'm concerned about, but not to take it. I don't recommend every client to take it away all the time, because some people can have a moderate amount of caffeine on the meal plan without getting cravings and without relapsing. So it has a little bit of a different pathway than like cocaine or sugar or something.
Thank you.
Okay.
I have a question as well, Bitten. It's Mary.
Yeah.
And when we look at the cross addictions or the aid, if we can, I guess I've heard things where addictive behavior is considered a learned behavior. So for the cross addictions, it just goes into that old learning instantly, or what, or is that just learned behavior doesn't adequately describe addiction?
I don't like the word learned behavior about addiction. I think it is an acquired illness. Neurons that fire together wire together. So, you know, if you have an addictive prone brain, you know, anything could be addictive, but, you know, because once it's going to activate the same behavior pathway. Learned, I mean, that's, I don't know, I don't like that word there. To me, it's an acquired illness. Because otherwise, you know, we come into the psychological stuff. If you learn something, you can unlearn it, but you can't do that with addiction. You can't unlearn it. I think Vera explained that excellent when she had her lecture. Once an addict, always an addict. Once you have those pathways, you know, they're going to stick there forever. So the difficult thing, I think, is why food is the most difficult addiction to treat is because it's so connected to survival, and we all need to eat. And then we have other addictive outlets like relationships, working, where you need to really have a recovery plan that is extremely focused, because you have to keep doing what could be addictive to you. Do you see what I mean? So that puts a lot of more effort into doing an excellent recovery plan than, like, for instance, taking away alcohol or opiates or cocaine. You don't have to touch the stuff once you take it away. So those are much easier to treat, in my opinion, anyway.
Thank you.
Bitten?
Yeah.
Can I ask? Yes, I was planning to ask, maybe, I don't know if it's the correct moment. I was planning to ask about tobacco. And what's the link between tobacco and sugar addiction? Because I didn't know, and yesterday in my group, we were discussing this, and I didn't know that there's the connection comes from, apparently, I don't know, I just want to hear from you, from the processing of the tobacco, that there are some sugars involved in the process, so that gets also in the inhaling the tobacco. Is that so, or?
Well, it's exactly. Nicotine in itself, it's very addicting, and there is a lot of research, things you can Google on the internet if you want to learn about nicotine's pathways on acetylcholine and the receptors there. But it's true that all nicotine products today contains a lot of sugar. So if you're a sugar addict and you go and try nicotine, you're going to be, you have, according to researchers in Sweden at the Gothenburg University, if you are addicted to one drug, you have 9 times higher risk to become addicted to the next drug, because you have once started to build a pathway. And people that are addictive prone, they like to try drugs.
Yes,
So,
but this means that.
Yeah.
This means that the cigarette itself has sugar, and you are inhaling that sugar. Maybe has a different impact, not from the blood, but directly in the brain. Because otherwise, we would see like any shifts in the blood glucose, which is it's not the case. I mean, normally you don't see that. You don't see like drops in the sugar, but so probably the via of absorption is different.
I have not seen any kind of research where they have taken people on nicotine and taken blood sugar on them without them eating. Then you have to have them starving the whole day and then do a blood sugar curve. I've never seen anyone do that. People that are nicotine addicts, they always say, I don't have a problem with sugar until they quit nicotine. Holy smoke. Then you can see it. And if you do, when we come to the sugar curve, you're going to see that sugar addiction starts between the age. Somebody is having, are not muted.
Can you please? Yeah, that was Romina who was asking.
Oh, there's background.
You muted now. Yeah, there's background.
Well, so I haven't seen anything in that way, where you take blood sugar when people use nicotine. But most people are nicotine addicted people. If you do a sugar test on them, they were sugar addicts long before they were nicotine addicts. And sugar also enhances nicotine to go faster into the brain. So even if you don't see the blood sugar problem, and when we talk about addiction, it's more important to think about how does it affect the brain, the neurotransmitters. That's the main thing we are focused on when we work with addiction. Blood sugar is second. So, okay.
Bitten, this is Sherry.
Yeah, hi Sherry.
Hi, under sugars, what do you perceive the effect of artificial sweeteners?
The same as sugar. I mean, they're very dangerous because, first of all, we have to understand that even thinking about sugary stuff or see sugary stuff, when we work with craving, I usually talk about cue-induced craving and stress-induced craving. And we know that, we used to say it moves into your head. So just seeing stuff that has sweetness in them or have the flavor on our tongue will start the addictive process. So, of course, the people that work with sweeteners, they would come to you and say, well, it doesn't raise blood sugar. It's no calories.
Okay.
But that's because they don't want us to talk of addiction and understand how an addicted brain looks and works. So, of course, they're going to, in the long run, give insulin resistance, and they're going to give you craving for other sweet stuff. So you are much more prone to relapse. That's my opinion about artificial sweeteners.
Thanks.
May I ask one question?
Sure.
It's Cynthia. The same when it applies to grains,
Yeah.
because your chart just says flowers, but it doesn't say grains. So how is the one addictive and the other is not?
Well, to me, in Sweden, we don't distinguish between grain and flour. Flour is grain and grain is flour. So, any kind of thing, you make into flour, if it is rice or, any of the teff or blah, 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 wheat or barley or grain is grain. And we don't use grain. We don't use flour.
Thank you. That clarifies a great deal.
Okay. And there is other aspects than the opiate affection of endorphins of grains, because you have to remember, once you chew it, it becomes sugar in your mouth and it goes into your bloodstream and it's going to affect your dopamine and it's going to affect, but also the reason grain is, grain made into flour is dangerous because of the villi in your intestines. And that's a whole nother lecture. Okay. We can then, I'm going to mention it when we come to biochemical repair. Here's some kind of background only. You can read about this, and I also put it in the material I sent out to you if you like to understand where these diagnostic tools come from. I have made sugar, the assessment tool we're going to talk about today, from Addis, which is made from suds. So there you have the connection. And we also have Addis Adolescent, which is a more extensive. See, when it comes to kids, it's more difficult to do a diagnostic evaluation of a teenager because they are so experimental. So you have to be more aware of the questions you ask. It's not as easy to diagnose a teenager because how teenagers are. And I have had a lot of questions now that people want me to do sugar adolescent, for maybe 10 years and up. And so I hope we can have that instrument in the future, but we don't today. We only have Addis, and that's for alcohol, prescription pills, and street drugs. So, and here are the 3 groups that I use, and that's very simple. I don't confuse it with anything else. So why is it important that we do a diagnose? Well, it really is unethical to treat the person without knowing what it is we're treating. Anyone would agree to that. And the risk for incorrect treatment in regards to abuse, harmful use, or dependency addiction. I would say that it isn't dangerous for a person if we take somebody with abuse, harmful use, and treat them as an addict. There's not a lot of dangerous effects on that. But if you do it the other way around, you are actually prolonging the person's illness. You are deepening the person's illness. If you think that it is only abuse, harmful use, and you really have an addict in front of you, that could be very dangerous, actually, if you think about it. So that's why it's important. And of course, we have all met patients that we can, after a while, see that, my goodness, this is a really sick person. with heavy-duty denial, heavy-duty addictive thinking, and you start feeling that if this person doesn't understand what's going on, they're going to die. So the important thing isn't that you and I can see the diagnosis, and see what is going on. The important thing is that we can, in a very loving and caring way, tell this person how reality really looks. What are the pieces together? What is making you sick? And that is also giving us the treatment plan. So how do I take you back to recovery? What is needed? That's why it is so important with the motivation part, and also realistic goals for this client. They all want to come in and lose 40 kilo in 3 days. We know that. But if they see the picture we can paint, the picture we can show them with this diagnostic tool, they can be much more realistic in what kind of road do I have ahead of me. And that's important. And also, what kind of treatment program we should suggest. Should we really suggest that they go home and do this all by themselves if they are a lone mother with 4 kids and no money? I mean, there are things that we need to look at in reality for each client, and we need to be adjusting the treatment plan after where we have the client and what they are going to be capable of doing. We cannot set too high goals for them, because they're going to feel failure and they're probably going to go back into doing the drug again. And one thing that is really, we all have read, food research, which is the screwiest research we can read. I mean, it could sound like this. Men in Finland that eat hot dogs get a heart attack. That's how crazy, it can be. And of course, okay, what do I do now? Here. And you start thinking, a lot of food research isn't that way. So, okay, hot dogs is dangerous, but nobody is telling you, did they smoke? Did they eat other stuff? Did they drink alcohol? So the only way you can really know things about food is that you lock people up in jail and you really check every little piece they get in there or out. And there are actually some of those studies showing that people in jail that got a lot of junk food, they were always fighting, aggressive, arguing, talking about the next crime, being very negative and very, very bad. And then there was another unity. I think this was the Stillwater jail in US. They gave them really nourishing food. That's the only thing they could access. And they also helped them to learn new lifestyles. And they started being empathic, caring, helping each other, talking about doing a good life. Because we all know that junk food makes you crazy. So that was really interesting. So I'm very, my clients come and said, no, this is dangerous and we shouldn't eat this and this is good to eat. And I said, hey, wait a minute, stop it. Don't read all that crazy things about food research. And that is why I think researchers, that want to do research. I had a university contact me about a year ago, and they wanted to ask me, do you think that people with bipolar could benefit from taking away the sugar? And I said, absolutely. Of course they would, because it's stressing the brain. But I said, if you're going to do research on bipolar, shouldn't you also look if some of those really are addicted instead? And they said, what do you mean? No, that's not interesting. I think that was really crazy. So, but that's the way it looks. So anyway, when we do this screening, assessment, and diagnostic tool, we have 3 levels of showing the client what is going on. The first result that we get from this instrument is knowing, and I mean knowing, not guessing, knowing, is it harmful use or is it addiction? So that is the first thing we know. And I'm going to show you that. And of course, people with normal social use, they don't come to us, so we don't have to worry about them. And if we ask them 2 questions on that instrument, we're going to see that we can't proceed because it is no, no, no. And then, you know, we drop it. So the first thing we know, is this harmful use or is it the illness addiction? In Addis, we have a presentation checklist, which we go through with the client too, but we don't have that in sugar. And I don't think we need it because we have something else that I'm going to show you that's so much better. And then from those answers in the questionnaire, we get the addiction development diagram, which I'm going to show you, which is my absolute favorite tool when I'm going to sit down with the client and tell them what is going on in their life, how does it look in, you know, relation to their eating, and what has happened through the years, and how bad is it, you know, and why do I recommend the treatment plan I do based on what I got from the instrument. And then we also have the symptom curve, and I'm going to show you all of these things so you understand what I'm talking about. And there is, yeah, we have the checklist there. I talked about that. And the next step, the first step, what you can do when you meet a client is the screening, which is just, you know, a very rough way of seeing, is this something, could this problem be in relationship with food, or is the problem something else? So you kind of sort it out. And I use the Uncope, which was made for alcohol, subscription pills, and street drugs. And I just rewrote it for food many years ago. And I've used it ever since. And it doesn't really matter if you have found something else that you think is very good to work with. I think the important thing is that it should be, you should really know your instrument by heart, and you should stick to it, because that makes it so much easier to see if something doesn't fit in, you know, instead of trying to use different screenings and assessments, you know, many different tools. So I have stuck with Uncope for sugar and alcohol. That's the first one I do. And I also made one, I took it further and have one for sugar, alcohol, prescription pills, and street drugs. Those are the most important screenings to do. And then if I see that in the Uncope, if somebody answers yes to 2 or more questions, you should do a deeper assessment. If they only have 0 or 1 yes, you know, everybody eats a little bit, you know, sweet things too much sometime. But if it is only one yes, you know, you don't have to really dig deeper on that topic. You need to look for something else then. But 2 or more. And since I've done many hundreds of these screenings, and then I've done, you know, the sugar and add this instrument after, which is, you know, the third step, I have seen that if somebody answers yes to 2 or 3 on Uncope, they are usually harmful use. 2 or 3 yes, harmful use. If they have 4 or more yes, it's really, you could be pretty sure that they have an addiction if you dig deeper. And there is one question that is very interesting on that, and I don't know if you have looked at it and you have figured that out. It is number 4 on the Uncope, which reads, has anyone objected to you overeating sweets? And also, when I ask the questions, I ask the client, what type of foods do you have loss of control over? And they usually say, well, it's, you know, chocolate and ice cream and candy and cookies and cakes and breads and pasta and blah, blah, blah. So, I mean, it's carb, carb, carb. And some people are more bread addicts or pasta addicts, and other are more like, you know, chocolate and ice cream. And then I asked them, could we use one word for all the foods you have loss of control over and call them sweets? So that we have to be me and the client have to agree on that before we start the questionnaire, of course. Otherwise, the questions will be really wrong. So anyway, number 4, has anyone objected to you overeating sweets? Has your family, a friend, or anyone else ever told you they objected to your eating habits? And what do you think most people answer on that one? Well, no. Of course. Why is that? Because we hide, sneak, and lie. So we usually, active food addicts usually eat normal when they are with people. But of course, when you're alone, that's when you overeat, binge, or whatever, what kind of behavior you have. So usually if the client have 3, 4 yes on the uncope, but they have no on that question, I'm so tough that I ask them, if they saw how you eat, how you did, how you behaved around food, would anyone object? And then, of course, 9 out of 10 will tell me, yes, they would. And I said, okay, let's put yes on this formula, on the screening then. So that's how I work it. And then, if the client cannot afford to do the sugar, or we don't have the possibility, or some of my trained counselors today are not certified in sugar, they can after the screening go ahead and do the clinical evaluation and biochemical assessment. And there are many tools there, like Jail Scale is a more in-depth interview. The one that I added to your material is one that I got when I trained with Parkside Medical Corporation in Chicago in the beginning of my work with my food addiction and other food addicts. So that's an interview which I added in your material. So you have that in your Dropbox, and you can use it if you want. There are certain lab tests we can take. Blood sugar curve, we can do a weight curve, fasting insulin, insulin growth factor, homocysteine, and many of these I can talk a little bit more about when I do the biochemical in an hour, well, in 20 minutes actually. But we all know that there is not one blood or urine test that would give the diagnosed food addiction. So that puts a lot of what should I say? Well, we, as food addiction counselor, we have to be very good at piecing a picture together from lots of pieces. Let me put it that way, because we don't have it in any diagnosis manual or so forth yet. But there is lots and lots of good tools out there that we can use actually to try to put the pieces together and see, oh my goodness, this really looks like food addiction. And the client's story, of course. And so forth. And then, of course, we have the diagnostic evaluation based on DSM-5 and ICD-10. And I have put another paper in your Dropbox about DSM-5, the new diagnostic tool. And we decided not to use that when we did sugar. And we based that upon what Terry Gorski actually said about DSM-5, that they took away the addiction concept and they sort of made it into some kind of a syndrome. So please read that paper and make up your own mind. But so I don't use DSM-5 right now. I only use ICD-10, which I also put in your Dropbox so that you can read about when it comes to diagnostic criteria. Okay?
Bitten, I have a question.
Sure.
This is Kathy. I was just wondering what your thoughts are on the Yale food addiction scale.
Well, to me, it's very complicated, and it's a very extensive screening instrument. But as far as I know, it's not a diagnostic tool yet. And I think you need a lot of training to be able to get something out of it. And when you look at the addiction development curve that I'm going to show you in a minute, you can see yourself how valuable that is compared to getting all those questions asked in the jail scale. But you know, I haven't really worked with it. So it might be really good, except that when I see all the questions and all the way you put it together, you know, I get utterly confused. It's too complicated for me. That's my personal opinion.
Bitten, can I ask, I don't know if I understood well, 2 or 3 yes is harmful and 4 is almost for sure that we are in front of an addiction, right?
Yeah, I can say by doing hundreds of these. I've done hundreds of these. So if the client had 4, 5, or 6 yes, and then I did the sugar, they were at, yeah.
Now, the point is with 2, for instance, with 2 or 3, but 2, let's say, do you carry on asking those questions? Because many times it can be like maybe the biochemistry is not yet altered, but there is still something in process being altered, and the behavioral thing. So that the only way you can know that is with those questions that you mentioned.
Of course, you know, if you have 2 to 3 or 2, you know, and you can still see, it could be denial. The patient could be, you know, not understanding the questions. They could have a biochemical denial, like Phil talks about. Absolutely, you're thinking totally right. But then you have to wait and see. If you have a chance to do sugar on that client, it might be much more clear what's going on really. But my experience is that if they have 2, yes, it's usually harmful use. Okay? And here's another one. You can read that by yourself, you know, different ways where you can, you know, take these instruments and go further into coming into, you know, a diagnosis where you can create a very good treatment plan. So sugar instrument, you know, now we're coming into talking mapping, and it's still not validated or ready-made in that way. We're working really hard in Sweden on that, to do as many as we can to be able to validate it and check its reliability, which I'm sure is going to go excellent once we get into that project. But anyway,
can I?
Yeah.
Sorry, I just have a, maybe it's a silly doubt, but does this evaluation process, this assessment, is exactly the same if the person not only is addicted to sugar, but also to tobacco and alcohol? How do you separate these 3? I mean, do you just go around asking more focused on sugar, and then you ask about other substances that might be consuming?
Okay, in the screening, you can ask about anything, gambling, you know, nicotine, blah, 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 blah. There are a lot of ways you can do that. And in the sugar too, we ask, of course, about gambling, we ask about nicotine, we check for alcohol pills and da, da, da. But then they are screenings. And if you want to make a diagnostic evaluation of those things that you mentioned, psychoactive drugs, you need to be certified in Addis too. And we only have 3 in the whole world that are certified in Addis. It's me and 2 more that have both sugar and Addis. And I'm working hard to make that happen. But then you cannot diagnose alcoholism from sugar. Okay, so there are 2 different things, Addis and sugar. But if we keep looking at sugar, then it's a therapeutic interview. Is one of the best ways to reach within the client's denial and defenses, to start connecting, you know, the dots. And when I have done workshops, you know, people come to me, and the first day I ask them, why are you here? Why do you want to do this workshop? And they say, well, you know, I have lately discovered that I have a problem with food. Well, you know, I have a lot of problems, but, you know, I'm here to take care of my problem with food. And then, you know, I do all the 4-day intensive training for the client. And on Sunday, when they go home, I ask them, okay, how do you look at the process now, and where are you standing? And they all said, oh my goodness, you know what I realized? And I said, no, I have one problem, lots of consequences. So that's what this is doing for you. the clients start seeing that it is because of their food addiction that their relationship is bad, that they don't have enough money, that they can't study, that blah, 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 blah. So I think that is, then you have done a successful treatment in my ways. Because, you know, addiction is really, if you're an addict and doing the drug, that is the main problem for you. So that's why this is a therapeutic interview. And another thing is, if you're certified, you can take any one of those 12 that I have certified to do, you know, sugar on the same client, and we will all get the same results. So it's very objective. It is not depending upon your opinion when you are a food addict or when you're not. And I think that's very safe for the client. So it's quality insurance for both you and your client. And it really aids the client in gaining insight, which of course going to affect motivation. And it provides you all the information you need to do a precise treatment plan. You know, where are they in, you know, their addictive process. So that's really good. And it takes away stigma. It really helps them understand that they do have an illness. It's not bad character or stuff like that. And if we look at the case study on this, this is one of my clients then, it's a couple of years ago, 46-year-old female, married, 2 kids, employed as a traveling saleswoman, very good economy, ambitious, always been weight conscious. She's always felt fat, and she had exercised daily and been obsessed with body weight and food. And the reason she came to me was that it was her employer that sent her to me because they were suspicious that something was not right, because she had not shown up to a meeting. And when she came back to the office that afternoon, she was very stressed, disheveled, drained, and very nervous. And then I start, of course, just a regular interview and asking her about her eating behavior and drinking and if she was smoking and, you know, all kinds of questions. And she tells me that when she was 6 years old, she started lying to her mom about food so she could go to grandma and just drink, have sodas and cinnamon buns. That's all she wanted to eat all day long. So she started to overeat sugar and flour and lying about it at the age of 6. She started dieting at the age of 15, and she started smoking at the age of 16 because the big ladies, big girls, told her that if you do that, you know, you don't eat so much, so you can lose weight by smoking. And I think that that is a very, very important question we should ask everyone that smokes. Why did you start smoking? You know, and you're going to find that a lot of people will say, I did it to suppress appetite. She started to drink at age 18. There are no trauma or nothing special happening here, but, you know, she was starting to go out dancing and meeting guys and blah, blah, blah. So she starts drinking and she likes it right away. And during 18 and 22 years of age, she's dating, partying. And then she meets a guy and she becomes pregnant at 22 and 26 years of age. And she gains 60 pounds each during the pregnancies. And of course, you know, a lot of women will say it was due to my hormones during pregnancy that I got so fat when I was pregnant. But, you know, if you really dig deeper, you're going to hear that they say, well, you know, before that I wanted to stay slim because, you know, I wanted to look good, but I knew I'm pregnant, I'm going to be fat anyway. So I totally let go on everything I ate and I only lived on junk food. That's very common, very common. But once she knew she was pregnant, she quit alcohol and nicotine, but she resumed both after nursing. And that is also telling you one thing. Addicts can quit anything for a period of time, but an addict will resume the drug. Somebody with harmful use, if they have been drinking too much or doing nicotine, if they once quit, they usually stay quit. But the ones that pick up again are the addicts. And after that, she can't lose weight. She starts binging and vomiting. And she resumed that alcohol and nicotine. And she started dieting and exercising vigorously, overeating, binging, vomiting at 29 years of age. And started having problems with marriage, work, weight. And she couldn't keep all the balls in there, as we said. So, you know, things starts to fall down around her. And the one of you that know the phases, the phase 1, 2, or 3 in the addictive process, going to see that she start going into phase 2 here at 29 years of age. If you put the curve here, you're going to see that. At age 33, she starts having health problems, migraine, body aches. She starts using Tylenol every day. And of course, we know how that affects the liver. That's very toxic for the liver. And she starts having mood swings. So basically what we can say, her body is starting to be biochemically very unbalanced. At the age of 35, she starts having sleep disturbances and periods of depression. So she goes to her GP and say that I work too much. I can't handle my family and my work, and I need better sleep. So she gets sleeping pills, Imovan, which is a benzodiazepine and highly addictive. So she started eating those. And at age 35, she continues having health problems. And now she's really concerned about what's going to happen to her body and her her psyche. So she quits smoking and gains a lot of weight. And she increases use of alcohol and benzodiazepines and feel even worse. At 41, her body can't handle all these drugs anymore. So she quit alcohol and benzodiazepines and smoking cold turkey, which makes her end up laying in a fetal position for 3 months during a summer, totally depressed and just eating. And as you're going to see on the addiction development curve, if you take away one drug and you haven't addressed the addictive problem, other drugs are going to get worse. That's just the way it works. And that's what the curve is so good for, seeing. At age 42, she got a diagnosis of fibromyalgia, which is very common together with food addiction because food addicts eat highly inflammatory foods. And fibromyalgia is an autoimmune disease that starts in your intestine, so we know that today. Usually also when we get people drug-free, you know, the symptoms of fibromyalgia disappear or lessen remarkably. And she goes into weight gain. And at 46, she gets diabetes type 2. Do any one of you think that this is a very strange client for us? Is it a very common client for us? Good.
Yeah, it's quite, yes.
Yeah, it's a very common client for us. That's why I picked her. And also because it's wonderful to see she has a great recovery today. But she seeks help anyway. And she comes to me because she wants to lose weight. Well, actually, her employer sent her, and I asked her, what would you like me to help you with? She said, I want to lose weight, of course. And since I have both certifications of both additives and sugar, I do both. I screen her for both, and I see that she picks up on alcohol and pills too, so I do both. And then on the checklist for food, I can see that she's a food addict. On the left, you see the symptoms, you know, the criteria in the ICD-10. And in the blue part of this, you see it says AAAA on every criteria, which means that she had more than one symptom during the last year. So you check, that's actual last year. And when I then look at how many symptoms she has, in how many criteria, this was DSM-4, so it was 7 criteria, it's 6 today, I'm sorry. She has 23 symptoms in 7 criteria, in all criteria. And in order to have the diagnosed addiction, you need to have at least 3 symptoms spread in 3 criteria. So we are not in doubt on her diagnosis, are we? No, it's pretty clear. And then we look at the checklist for alcohol and sedatives, and we can see the same checklist, of course, and she has on alcohol, she has 8 symptoms spread in 6 criteria. And on benzodiazepines, you know, the sleeping pills, she has 10 symptoms in 7 criteria, which is just totally clear. She's an alcoholic and she's a pill addict. So any questions about this? Are you all with me, what I've done here? Good, good. Okay. And then, so that is the first result that I get from the sugar instrument, sugar and addis, which I did both here. Then from, and the clients only, it's an interview, so they don't fill in anything. I sit and ask the questions, so that's why you need to be certified, because you need to know your material and you need to understand addiction when you do this. And that's why you ask a question, and if they say no, of course you jump to the next question. But if they say yes, you have to understand how you continue to following questions like, has that happened the last year? Yes or no? Have you done it more than once? Yes or no? And at which age did you experience that symptom the first time? So there are many follow questions on each question. So that's why you need to be certified in using the instrument. So once we have that, we come to this curve. And if you look at the curve, if you look at the left, you have symptoms 1 to 24. That it is a total of 90 questions in addis and 71 questions in sugar. And it's a total of 74 symptoms that are addiction symptoms. Of course, there are other questions, but they are, as we say, star marked in the interview, the questions you use for especially the addictive addiction diagnose. And they are a total of 24. And on the top, you see the age, which of course, you know, differ from clients. So you put her age in there. And 6, remember, that was the first time she remembers starting to sneak with food. That's why I put 6 there. And then she is 46 when she comes to me. So that's why it ends with 46. And you just divide up the cubes. So it's pretty equal. And then you see at 22, pregnancy 1, at 26, pregnancy 2, and 42, F stands for fibromyalgia, and 46, diabetes type 2. And on the right, you have weight. So you can see the weight scale there. And then you can also see that we have color-coded things. So you see that nicotine is purple, alcohol is green, sugar is red, weight is blue, and benzodiazepine, the sleeping pill, is yellow. And once I have done this, I sit in front of the computer with my client and we go through this together. You know, here is the result from the questions I asked you based on your answer. So that's what I tell the client. And now you can see that at age 6, she has 2 symptoms on addiction already. You see the bar go straight down, the red, and that means that she has 2 symptoms on addiction. And this is very normal. Usually they have the first symptoms of addiction between the age of 6 and 10 years of age. Almost every client has that. And then you see
Between
that...
what ages?
Pardon me?
Between what ages?
Here on the top you have age. On the top of the scale here. Was that your question?
6 and 10.
No. You said that normally between what ages is the beginnings?
Yeah, 5 to 10. Most clients that I meet as adults can, when we do the interview, can see that the first symptoms of addiction was between the age of 5 and 10 years of age. we really see very rare that the debut is later.
Bitten, what were the two first symptoms? Lying? Is that an eating?
No. This is in the, I don't have the number of the questions, which ones, but, you know, it could be stuff like, I didn't have those numbers.
Oh, it was sneaking with her food.
Stop. No. The interview I did first to ask her when she thought she had problems with food was that she told me she was starting to lie, hide, and sneak with food at the age of 6. But the two symptoms she had in here, they are symptoms related to the instrument we're using. Okay. It doesn't necessarily be the same.
Thank you.
Yeah. Okay. So it's two different things. And then you see, between the age of 6 and 14, you know, the illness is in a plateau, so there's no new symptoms. And then at the age of 14, she has 3 more symptoms. Now she has a total of 5. This is also extremely important to show the client that this is a progressive disease. As you're going to see, it doesn't go backwards. If we don't arrest it, it's going to go downhill. And we have a plateau again, and we have 1 more symptom at the age of 18, and then we have a plateau, and then we have 1, 2, 3, 4 more symptoms at the age of 20, and plateau, and so forth. So you can see that she's going all the way down here to 23 symptoms, which you saw in the checklist too, that I recently showed you. So this is her progression of her food addiction. And, you know, most clients gonna say when they see this that, my gosh, I thought it was bad, but I didn't know it was this bad. So this is a way for them to really come closer to see what this disease has done with them all their life. And also the way they have been trying to control it. Of course, they can't control it, but been trying. And then we put, yes.
Sorry, have you always found these 5 to 10 years during the childhood that there was this event that the person can recall? Or sometimes not, like someone like an addict who starts smoking or with alcohol, maybe just they get the hook of that. Can this the same happen with food as well? Or they always recall events from 5 to 10 years old having issues?
Most people know that. Most people can really recall early because the questions are asked in a way that they do understand. They can look back. Absolutely. Most people can do that. And that's what's so wonderful with this instrument, that the questions are asked in a very special way. Absolutely.
So maybe in this case, it can correspond what before, like a big amount of people sustain the issue of trauma. Does this correspond with those ages and that trauma associated with food addiction?
Well, you know, everybody has some kind of a trauma, big or less, but that is not the cause of addiction. I'm very firm about that. So I'm going to show you when we're done with this chart how you can look at that. But many, many times, you know, trauma, the effects of trauma come later, as you're going to see once I'm done with the whole curve. So they know.
I have a question.
Sure.
Have you seen any correlation between someone who is born with the addictive predisposition or the biochemical predisposition and their susceptibility to trauma?
Well, you know, to me, I think before we had high fructose corn syrup, because which I think should have its own chapter on causing addiction, you know, without the biochemical or genetic susceptibility. I think it was very easy that anyone that developed an addiction must have, you know, some kind of genetic sensitivity in order to be addicted. So to me, that's simple. So of course, most of those clients have grown up in a family with some kind of addictive or dysfunctional behavior, which of course add to this. But still, you don't. We don't mix. It's still very important that you keep those two things apart: the trauma and the addiction. That you don't think that the trauma caused addiction. But the problem is that addiction really distorts the trauma tremendously. So the patient is not in touch with the trauma, or are not capable of dealing with the trauma, no matter if it's small or medium or big, until you take away the drug. So that's why it is so important to understand if you're addicted first, before you go ahead and deal with the trauma. And also, if you work with someone that has a trauma and they are still doing the drug, you could exacerbate it very, very poorly. You could be very, very bad. So that's why we use this to see that. But of course, I'm going to show you, because I think I can answer your question even better once I'm done with the whole curve. Okay? And yours too, Maria.
Bitten, can I just add a thing? Because we're over the time, but I want you to really finish this, Bitten. And so I'm going to ask people not to, ask questions. Try to get them on chat or write or something about questions for this. And we can talk about some of those questions afterwards also with me. So
okay,
go ahead, Bitten.
Okay. And you see that she quits smoking when she's pregnant, and she starts when she's not, and then she quits smoking again. You see that purple line down here? And then we take in the green line, which was alcohol. And then you see something interesting. When she started with sugar at the age of 6, she got 2 symptoms here and then plateau. And now when she brings in alcohol, she got 1, 2, 3, 4, 5 symptoms right away. And here you can see what scientist is telling us. If you have one addiction, it's much easier to develop the next addiction, because the pathway is already wired. And you really can see this when you do this curve. So that is extremely important to keep track of and tell the clients about. And then, of course, she drinks, pregnant. She quits drinking during this period when she is pregnant and nursing and have little babies. But she starts drinking again here at 29 and gets 2 more symptoms right away. And then we have this plateau, and then she has another 2 symptoms here. And remember I told you that she had sleeping disturbances? Oh yeah, the thing is too, when she can't lose weight after the pregnancy, she starts binging and vomiting. Somebody tells her, why don't you put your fingers in your throat? You can eat anything you want, and bingo, you can lose weight, as you're going to see in a little while. And then at 37, she starts on benzodiazepines. And now, check this. How many symptoms does she get right away with that? Well, 7. So 2 with sugar, 5 with alcohol, and of course you have nicotine together with alcohol right here. And then you have benzodiazepines, you have 7. If she would have added on another drug, it would go faster downhill for each drug she would add on. Because once you have the pathway, next drug goes faster. We know that through science, and here you can see it. This is the way the curves look. And you also see how fast she starts really using the benzodiazepines and overdosing and get a lot of negative consequences. And as I told you in the assessment, she starts with, well, I see that the lines get a little screwed when I put it up on the screen here. But actually, at 39, she quits benzodiazepines, the yellow line, and alcohol, the green line, and nicotine, the purple line. And that's when you see here at 40, it says DNA, which is depression and anxiety. That's that summer when she's in a fetal position, totally depressed. And she don't understand why. she thinks that it has to do with her life situation, but as an addiction specialist, we can see why this is. Because if you quit benzodiazepines, alcohol, and nicotine cold turkey, your brain gonna go bonkers. So no wonder she's going into this crazy feeling. And if you look at the weight curve, that is the, you know, icing on the cake. We shouldn't use that expression here, but it's fun anyway. You can see, really see how this connects. Before the age of 16, she's not aware of her weight. She say that she felt chubby all her childhood, but when she looks at pictures, she wasn't. But anyway, she started smoking and drinking here, and she lost some weight. That's the blue line. And then she got pregnant, and she really gained a lot of weight. And she started to binge and vomiting after, so she loses weight. And that is one reason she goes into depression and anxiety too, because she's nutritionally deficient, of course, you know. It's not only, you know, quitting benzodiazepines and alcohol and nicotine. It's also, you know, she doesn't have a good nutritional status because of the binges and the vomiting. And of course, it's junk food. And then once she quit these other drugs, you can see that, look at the red curve here now. You see where the yellow, green, and purple curve quits. And then you see that it has a plateau here during the age of 25 and 38 because she's doing other drugs. She's binging, vomiting, she's using benzodiazepines, she's smoking, and she's drinking alcohol. And now she quits those. And then you can see the red curve really going way down. Do you see that? How fast it goes down here? And then look at the weight. See? You see how they go apart? So when you sit with the client like this and you go through it slowly like this and click each thing out like this and you tell them, you know. And here is Lior and Maria. You asked about trauma. Of course, this depression and anxiety here, we don't know if that's a trauma. It could be biochemical imbalance. So we need to treat that before we can do anything about trauma. And I'm trained in US when it comes to alcohol, subscription pills, and drugs, that you should not do any psychotherapy on a client unless they have been sober and in recovery for 2 years. It could be very dangerous to start working deep trauma on an addict because their brain is not healed. And I take that with me, and I can see that with food addicts too. People that go into dealing with childhood issues or deep therapy too early, they are really prone to relapsing. So we need to stabilize the client very well before we start working on the trauma piece. But here is where you can do that. You could, like for instance, if she was, you know, physically abused when she was a teenager, or some trauma, maybe she was raped, or, you know, some incest or whatever had happened to her. When I sit with the client and I talk them through their life and look at this, we add that in here. We write it in so that we know, well, what do we have to deal with once you are stable and drug-free? Is that an answer on how we deal with it? Yeah. But what I see many times in Sweden is people, you know, they're only interested in the trauma. They don't understand the psychoactive danger of drugs. So they want to talk trauma, and they want to work with trauma. And I think that's very dangerous on biochemically imbalanced people.
Okay, Bitten. So how many minutes do you need to kind of finalize this one?
Two.
Okay.
So,
then we'll have a few minutes break and start again.
This is just showing the client, you know, where they have symptoms, phase 1, phase 2, and phase 3. So this is just the same as the last one, but simpler to see. So here you can read about, you know, how we use this as a motivational therapeutic tool once we have done this and gone through it with the client. And I can see that once you have done this in-depth diagnostic tool and sat down with the client and motivated them, they have a much higher compliance, and is much more interested in their well-being and much more understanding of that this is going to take time, and I need to really develop a new lifestyle and a lot of new recovering tools. And it cuts through denial. Okay, Esther, I'm done with this. Shall we have 3 minutes?
Thank you, Bitten. This was wonderful. And I'm sure everybody has like a trillion questions to ask, and we can do some of it after your second lecture, and or you can kind of gather your questions together, and we'll send it to the group, and Bitten may or me, to answer. Okay, let's take about just a few minutes.
Sure.
For just a short break, no more than 5 minutes.
Okay.
And it is on. And what Bitten was asking was if there were any question concerning assessment and mapping and the sugar ARIS. If there were any such questions, he would like to take them at this point. So we can finish those so she can just go into the other lecture. So questions.
When can we get trained?
Oh, sweetie, I would love to train you tomorrow. I know you would be excellent at doing this, Cynthia, with your background. I would love to start the training this fall, actually. And I'm planning to do that and doing it, the webinar, like we do this type of training. And the thing that I have to penetrate a little bit more just is how we do with the instrument, sending them back and forth. If we can do it digital on the computer, or we have to mail them. Otherwise, I have the program ready. So I can start in September.
Sorry, I'm just joining the conversation late. Are we talking about the sugar ARIS?
Yeah.
Yeah.
The sugar. So if you're into, anyone that is interested to have this training and be certified to do this instrument, to work with it, please give me a mail and I'll let you know.
And it's only available in Sweden right now, is that right?
Well, I develop it, so it's only available through me. I'm the only one that can certify you so far. I'd love to train Esther. I love to train anyone that will train with me so that more people can teach and certify people. But for now, we only have it in Sweden.
So are the 11 people that you referred to as being trained or certified, are they all in Sweden?
Yeah, they are 12. 12 is trained. I have one in Norway being certified soon, but she's working on her nurses program, so it will be a while. She's going to be a nurse. Otherwise, we have 12 trained, 13 with me, and then we have 3 that have double training, double certification, both ARIS and sugar in Sweden. But I think it is the instrument for the future, actually. I don't know. I'd be happy to hear. What do you guys think? Do you think it is useful, or?
This is Sherry. I may be jumping ahead, but if people have these multiple addictions, including, it could be process addictions, and if I understand correctly, that you would need to address all of them at the same time in order to be
I was going to ask something in that regard as well.
Well, Sherry,
yes.
As of today, there are not, specific instruments for each of the outlets. That's why I love ICD-10, because you could actually add everything on in there. But the thing is today, what we're doing, since we know that sugar and flour is in 99.9% of all addicts everyone that has an addiction is the number one drug, the first drug that everybody comes in contact with, that first drug they become addicted to. It's most important to do that first. And then you can do the screenings on all the others. Those instruments we have. So you see, if you do a screening and see, oh my goodness, this one is gambling day and night and, you know, live on sugar. I mean, you need to do that. But the problem with addiction interaction disorder, in my eyes, is that we are still too specific in our training. I mean, we train for food addicts. We don't work with alcoholics or sex and relationship addicts or so forth, you know, gambling or what have you. But I think that we need to train more addictive personality, addiction interaction disorder. We need to develop our training way into that type of a field, because that's what we're going to meet in the future. But we need to work with multidisciplinary teams. So let's say that you would be interested in gambling addiction, and I will work with food addiction. I send all the gamblers I find to you. I think that's the way we have to work. You know, the ones that will work with any outlet, it has to be in a professional in-house treatment facility if you're going to take away all the drugs at once and deal with the addiction like that. And as far as I know, we only have maybe 2-3 such facilities in the whole world. But we can do a lot. You could do a beautiful amount of work if you could screen for gambling, screen for sex and relationships, screen for working, screen for drugs, blah, 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 blah. And you know, find the food addiction behind it.
Bitten, when you have, let's say in a patient, the main issue is food addiction, but also suppose smokes. How do you phase the treatment? You just tell her, in the case of this patient, this woman, okay, we are going to start with a core thing that is a food addiction, and then maybe later on we will deal with.
You have to understand the addictive brain. If I have a patient in-house in a treatment facility, I can take away anything, any drug, any outlet right away, smash, bang, because they are in a safe environment. If you have them in open care clinic, you have to be really knowledgeable which to take first. And you always take, if it is sugar and nicotine, you always take sugar first. And once they are stable on the food plan, at least 6 months, then I go for the nicotine. That's the way I work it, and that's the way my experience has shown me is the best way, not the other way around. Not nicotine first and then food.
Bitten, I have a question. You know, if you look at that chart you developed with this case, she had stopped cold turkey with drugs, alcohol, nicotine, and then the food use increased. And so if you treat her for her sugar addiction and you remove the sugar, I would guess the opposite would be true, and that is she could start using those other drugs again if you remove her primary addiction potentially. Do you watch for that? Do you assess for that? How do you?
Absolutely. And when I treat somebody with a food addiction, and I know they have nicotine, alcohol, and drugs, you know, that client, if she had come to me when she was active with all these, I would send her to a professional alcohol first, because I write that in my paper too. If they have prescription pills, street drug, and alcohol, and the food addiction, safety first. You have to take away the most dangerous outlets first. So you send them to an alcohol specialist, and then you deal with it, not the other way around.
That makes sense. And that makes sense. What I saw though is because she quit cold turkey, and she wasn't using.
Yeah, and then you saw what happened. And this is what happens. And I had clients that say, well, you know, when I took away sugar, then I started wanting wine all the time. I mean, that's the way it works. So you have to be aware of that. And you address every outlet. You always talk about addiction interaction disorder, addiction interaction disorder. That's what you do. Yeah. And you be aware of that. And once you get clients to surrender, once they surrender and understand addictive brain, you know, the reptilian brain, the mammal brain, and the neocortex, and what addiction is all about, they will tell you about other outlets. They will come back and tell you, you know what, I'm starting being obsessed with training. My goodness, what's going on, you know? And you address it. If they don't have any, and that's why I think that and I'm going to come into that now in a second in this new lecture, my vision for the future is we should not treat clients, we should educate and train them. I like to call it education and training, not treatment. Because they need addiction knowledge like crazy. Okay? So Esther, shall we go?
Absolutely. Go ahead. Next one, Bitten.
Okay. You're going to do a test on this one, on the citric acid cycle. I'm going to wake you up 2 at night and you're going to say all this to me. No, I'm kidding you guys. But actually, a lot of us that were studying this when we were in nursing or doctor's training say that this is the perfect example that we are not made to use carbohydrates. And I totally agree. So our bodies are not made to run on that if you really understand this one. But we're not going to go into depth on this one right now. So, okay. The old way of working has been, you know, the psychosocial approach with addiction. And the new view is the holistic addiction treatment. I think it's very important that we work with the biopsychosocial and spiritual, the whole human being. And we are very well trained in thinking that things are psychosomatic. You know, like if somebody have a headache, we say that it's stress, or they have a back pain, you know, it's trauma, or, you know, we think that any kind of physical problem can be, something in the mind and psyche expressed as pain in the body. But we need to understand that it's really equally important to understand the word somatopsychic, which means that if you're biochemically unbalanced, your intestinal flora is, you know, crazy, you have vitamin deficiencies, you have a blood sugar going like the worst roller coaster, you can be very sad, very aggressive, and very depressed. So that is somatopsychic. So when clients call me and said, you know, well, I feel really bad, I don't know what's going on, and I'm sad, and my first question is always, what did you eat yesterday? What did you eat? Not what happened. What did you eat? I always address the drug or the food first. And then I can keep looking. And I also used to say, oh, we are the last house on the street. I mean, the clients that come to us, my God, if we sit down and ask them, what have you tried through the years? If we ask ourselves, what did we try through the years? I mean, this is probably nothing, all the examples I write on here, but they have really tried things like crazy, you know. I don't know if you have had a client sitting in the balcony in minus 20 centigrades trying to freeze her weight off in a bikini in the snow, but I have had clients doing the absolutely most crazy things in order to control the insatiable appetite or this problem. So we know their bodies and their psyche is not very well tuned. We can agree on that one. And also, our clients have looked for a solution high and low. They have been to so many kinds of doctors' offices and healthcare clinics and nutritional experts and training gyms, and I mean, we know. So they have gotten all kinds of diagnoses and pills and powders and, things that should cure them, blah, blah, blah. And the sad thing that is many of them, of course, look to the healthcare system for help. And I have had clients that have all those diagnoses you see on this chart, but they really didn't have any of those diagnoses. And once I had this psychiatrist call me, and he said to me, calls and tell who he is, and he said, what have you done to my clients? And, as a nurse talking to a psychiatrist, you think that, my God, have I hurt her somehow? And now he's going to kill me, sort of. So I was scared shitless. And I said to him, what do you mean? And he said, well, this client has gone to my office for some years, and I put the diagnosis borderline on her. And I said, okay. And now she came back to me, and she doesn't have a borderline anymore. So I'm very curious about how you work. And of course, you know, a food addict can look like a borderline to somebody that doesn't understand addiction, because they can be really crazy, and we know that. But he didn't know that, so he wasn't really out to, you know, punish me or anything. He was just curious, and that was interesting. So of course, you know, we can see all these things, and the important thing is that some of these clients that we see that have this are actually a real dual diagnosis. But if we work with holistic addiction treatment, we're going to see that most of the symptoms that we have in those diagnoses can actually disappear if we get a client with addiction healed. I have seen that so many times in AA and NA. And the difficult part today is that the pill industry, you know, they don't like my way of working. They want to find a pill and find a diagnose, like, you know, the amphetamine pills with ADHD, I think is an absolute disaster today. So many alcoholics and drug addicts, you know, and also many of them don't get proper treatment either, and nobody teaches them about the food and the brain and the intestines and so forth. So of course they don't feel well. So they go to the doctor's office and they get a new diagnosis and new pills. It's an easy way out, but it's extremely dangerous, extremely dangerous. Addicts should be as little as possible within the hands of somebody that doesn't know addiction. That's my opinion. So we need to train the medical staff to understand addiction. I don't know how to do that, but somebody of you might. Because we know this is a disease that never goes away. The addiction memory circuit, or euphoric recall as we call it, is very strong, and the illness is cunning, baffling, powerful, and very patient. And we also have a new synthetic drug on board. You know, we could talk a lot about this, but I think it's extremely dangerous, which Teresa pointed out last Saturday too. And I'm sure many of you know that and is very aware of that. And it is a synthetic drug in my world. So I'm not going to linger a lot in this, but when I work with a patient that come to me that has been a food addict, or maybe alcohol or something else too, or, you know, had a very poor lifestyle, I understand that they are very, very unbalanced in the biochemistry and nutritionally deficient. So I understand that a lot of these things are going on, and we can't work on everything at once, but at least I can be aware that these things are here, and that I need to start looking for how these things are imbalanced, you know, in which way, and understanding too that everything connects with everything. So, you know, if somebody has a burnout, I start looking for leptin resistance, insulin resistance, you know, and how the food have affected their stomach, and if they have low cholesterol, which causes chronic inflammation and depression in women, and so forth. So it's just a little overview to show that everything connects to everything, and we need to address all of it. And we know that foggy brain, that's a term we use, you know, with our food addicts. And here are some of the symptoms that I meet with the clients that come to me anyway, that they have very low energy and endurance problems, extreme fatigue and sleep disturbances. They used to say that I'm wired but tired. That's a very common term. And I have such a hard time concentration, and I can't really handle my job well, and I'm irritated with my kids, and blah, blah, blah. And they are restless and have impulsive, hasty decisions. And also when you look at the triune brain, you know, which Vera talked about, you know, very good. and I talk about the same with my clients, you see that they operate from the reptilian brain all the time, and they have not developed, the neocortex or the limbic system, and that's why they have all these problems. Difficulty organizing and keeping the structure, and the feeling of chaos when things are slightly disorganized, coordination problems. And we know that, for instance, coordination problems, you stumble and you fall and you're, fumbly, is low dopamine. And a lot of this is, of course, neurotransmitter problems. Severe mood swings, problems communicating. And long-term bioimbalance leads to negative, irrational thinking. Teresa talked about this too, ANTs, automatic negative thoughts, memory problems, emotional distress, and stress-related problems in all areas of life. But one of the things too, oh, I love that cat, Lior, the cutie. One of the things we see, and one of the things that I'm very cautious with any type of deep psychotherapy in the beginning, is due to false feelings. Then I mean feelings, we know the detox symptoms, and we know how people are in the beginning, really moody. And a lot of times, I think the 12-step program is absolutely super in, the slogans are really exactly tailored at this type of problem. Don't think, just do, one day at a time, all these kind of slogans we have. This will pass too, da-da-da. So I think that is the most important thing to teach people in the beginning, that this will pass. These are false feelings because you're so unbalanced. Analysis creates paralysis. It's another saying that I like. And this is a simple program for complicated people. I love that one. And how the clients in the beginning are going to make everything so complicated. They could screw up an anvil. So we need to take it down, because actually they do have problems with this. Their brain is not properly wired yet. So that's why they have a lot of these problems. And once they are out of that, dark place, we can start talking about, the real feelings and, how we deal with those in recovery. So here is some of the causes behind the false feelings. I think that many of you might have read about dysbiosis, the microbiome, how extremely important it is, because we do have neurons in our intestines. And of course, if you eat a lot of junk food, you're gonna, or you might have been having to take antibiotics because you have inflammations and other pills and so forth. You might have totally wrecked your intestinal flora, and that will absolutely affect your brain. It's a lot of very interesting research about that nowadays. And the areas affected is, of course, stress and what Gorski calls post-acute withdrawal, which I think is the same as burnout. Personality changes. Basically, when you look at these symptoms and you see how the clients react, what I like to say is that they don't have enough mental horsepower to juggle life. They are drained of energy in all areas of life, physically, psychologically, socially, and spiritually. And that is what the problem is. So one of the things that is very important is to restore energy for our clients. Many times, you hear, people say, well, she's not motivated enough. She needs to go out and eat more, and she needs to hit bottom and all that kind of bullshit. I think it's very dangerous to have that attitude instead of understanding that, wait a minute, what is the biochemical imbalances here, and how can I help this client? So, there's a lot of things that we in the beginning of recovery think that this is, which might not be. It might be something else, So that's what I like to add into, you know, the holistic treatment of a client, that look behind this old way of thinking, the psychosocial way of thinking, and look into biopsychosocial and spiritual, that it might be. I think that there is, I think actually what is lacking a lot in, you know, the medical society, and even among many addiction counselors, at least in Sweden, is the knowledge and the in-depth understanding of how horrible the drug destroys the brain, how disconnected the brain gets, you know, the physical, the lack of nutrients, because the brain is made up of what you eat. So I think that is very important for us to restore that knowledge.
Excuse me, Bitten. What did you say PAW stands for?
Post-acute withdrawal. And that is the same symptom as the burnout, the slide I had in the beginning. Gorski actually understood that. He taught me that many, many years ago, that post-acute withdrawal is actually a severe biochemical imbalance, that they thought at that time they only saw people that, you know, drank, did drugs and pills at the same time. They were sort of frying their brain. But if you understand the microbiome, the intestine, you can see that today's junk food is doing exactly the same. Exactly the same. So that's why biochemical repair to me is that you, in a more structured and organized way, heal the client, to restore energy to the client in all these areas faster, so the client have a better chance to start the recovery activities. You know, they come up on the road faster. It is not anything we should use as the treatment or instead of all the treatment. It's not. It's an added piece of knowledge and an added piece of thing we need to help our clients to achieve in order to be able to. And also, not everyone needs it. Some people, you know, they just go into recovery and chug along, everything works fine. But many of them have a hard time starting recovery. They slip, they lapse. I wish I had understood this when I started. And I worked a lot at that time, and I, you know, didn't know so much about good food either, because there weren't so much knowledge about that then, 23 years ago. But I can see the difference when I have a client that is really drained and I work with biochemical repair, contra when I don't, on a client that doesn't want it or can't afford it, or, I mean, could be many reasons. I see a big difference. It could last 6 to 12 months, and, you know, if you read about neuronutrient therapy, it takes 12 to 18 months to restore a body that is very unbalanced back into balance. It can worsen from confrontation and low response to psychotherapy because they don't have the mental horsepower, and recurrent when stressed. And it could be regenerative, slowly getting better, which in the most cases I've seen it is. Periodic, comes and goes, yes. We call this recidive, you know. Recurrent illness, that's what ASM talks about in the definition too. Or stable, or degenerative. So it's important to learn how to assess for these things and put the right treatment in. I have an example if we have time to do that one. This is a 24-year-old. She came to me from, her parents knew me, and they told me that she had been a sugar addict since childhood, and her favorite foods was pizza, spaghetti with ketchup, and cinnamon buns, I mean cakes and cookies, and some sweets too, but it was basically bread, and that type of thing, flour, grain. And she got diagnosed with ADHD and Asperger at 17, and she was put on Concerta, and that's of course an amphetamine. And she's a volume addict, which I can see a lot is addressed, well, it's a lot has to do with oxytocin deficiency. And we also know that in order to restore oxytocin, you need to eat protein and fat. You can't eat a lot of carbs because that drains your body of oxytocin, but I come to that. She had 44 pounds overweight, severe acne in her face. And that also made it, of course, that she did not want to go out and see people, meet people. Serious attention disorders. Look at the burnout, look at Pa. You can see what kind of symptoms she had. And she was, in her family, sort of, labeled the lazy one, the lethargic, lazy one. Nothing was really interesting. And she didn't care for her dog. She didn't do her bed. She didn't take a shower. Everybody had to nag her all the time to do all the things. I started working with her. And one of the first thing I do is I take a fatty acid profile. If they can afford it, since I work private, not everyone can. But if you look at, this is a summary of the fatty acid profile I use. And the protective index, this is the fatty acid around the cells and the neurons. Fat is extremely important as, the packing around your cells. And it's 0, which, if we can't reverse this, she can be incredibly sick. Her omega-3 level, and we're talking about animal omega-3, not vegetarian omega-3. You need to have animal omega-3 in your brain. 4.8, which is way too low, it should be 8, within the green. And the ratio between omega-3 and the vegetarian omega-6 is 12.6. It should be 3. And her omega-6, vegetarian omega-6 level is 66.3. It should be 45. And
skyrocketing.
Yeah. And if you have that high of an omega-6, you probably have a lot of arachidones, fatty acid arachidone, which is very pro-inflammatory. So omega-6, you should be very cautious with that one. And in her case, of course, the omega-6 comes from flour and grain because it contains a lot of omega-6. Anyway, the one I used today, that was at that time I used the forerunner to this one, which was a very simpler thing. The one I use today is much more extensive, and if you want to use Google Translate, you can go in and read at Arctic Med, which is the Swedish equivalent I do, and we send the blood test to Germany, to a laboratory in Germany, and it cost around 1,000 crowns. And I looked up, is there anyone doing something similar in US? And yeah, it was the omegaquant.com. So I found you a link where you can read about this and why it is important that you do it. So, and I don't work with clients now, but when I did, I got a link to Arctic Med. So the client sent for the test, did it in their finger, like you do a blood sugar, and they sent it to Germany. They paid for it. And then I included to look at the test result and talk to the client in my fee for working with the client. So it was very simple for me to use it. I didn't have it in my office or anything. But you can read it there anyway. Here are some of the tests I use. I use 9 tests on my client when I do a biochemical profile. I do the neurotransmitter dominance to see what they're born with. And as you see, D is dopamine, A is acetylcholine, G is GABA, S is serotonin. And you can immediately see that GABA is very low. And dopamine and acetylcholine dominant people are very speeded. They are extremely speeded. And you need to read the book to understand this because I don't have time to go into it. But GABA is the most important neurotransmitter to break down the body, and oxytocin, of course, it's the deep break, you know, the one that's going to slow the whole system down before you go to sleep. So you have a deep sleep and a deep rest. That's how you restore everything during the night. And people with GABA breaks, they always say, I sleep, but I'm not restored when I wake up. I'm still tired. That's a lot of the symptoms they have. And then if I look at the deficiencies, she has 11 on dopamine, 9 on acetylcholine, but look at GABA. Look at the deficiency. Up to 5 is normal. So she has a low dominance of GABA, 12, and she has a tremendous deficiency, very high. So no wonder this young woman, she never breaks. She never have a rest. She never restores. She never synchronizes her brain. So everything is just spinning around. So no wonder she is totally tired, lethargic, and I mean, she doesn't know what to do. And she has also a phase 2 of dysbiosis, which I need to address, of course. And she doesn't have such a high number on the metabolic screening questionnaire, which is one thing I use. And that one I put in your Dropbox file, so you can look at that if you want. But look at her adrenal fatigue. It shouldn't be higher than 25, and it's 70. How can a 24-year-old have a burnout and, you know, have adrenal fatigue? Well, because she has no breaks, she never rests, she never restores. And on the saliva test, she's very positive, and that's for candida, you know, the dysbiosis. I'm sorry I have to go so quick through this in order to give you a review, but if you want to know more, you know, please contact me. I give you more in-depth knowledge about it. Anyway, after 1 year, look at the deficiencies. Dopamine 5, acetylcholine 5, GABA 10, and serotonin 0. So, I mean, better than that you can't have. That is excellent numbers. She has no dysbiosis. Her MSQ is 25, which is excellent. And her adrenal fatigue is 0. She's lost 12 kilo. She has no acne. And she's bonding with peers, family, and social life. She started to practice in a store, you know, selling clothes. And Concerta is down from 54 to 18 milligram and slowly decreasing. And that's not anything I do. I have them do it with her doctor. So I don't touch prescription pills, you know. So if the client said, I want to quit that, I said, go to your doctor and ask for a detox. And other things we see is that she takes care of her dog. She showers daily. She's learned to cook. And finally, we can address, you know, even the addiction part, because she had other outlets. I don't have time to go into that, but she's in treatment. She goes to NA meetings because they didn't have OA in that town at this time. They do now. So now she goes to OA. She had many sleep lapses and relapse prevention work. And of course, she finally got there. Focus and concentration is so much improved. So what miracle drugs did I give her? Well, I worked with the family, you know, to teach her to cook and eat better. I gave her magnesium, B complex, zinc, xenitol powder, which I found it's inositol. And I think it is excellent for people that have spinning brain, you know, when they go to bed, because it usually stops all the thoughts and they can fall asleep. I gave her fish oil. I gave her enzymes that helps break down the food. I gave her D vitamin, and I gave her GABA, you know, double dose twice a day, and B6 at bedtime because it helps take up GABA. And I gave her hydrochloric acid because she was really deficient in hydrochloric acid. So her stomach didn't break down the food either when she ate something. And I put her on amino acid complex, which is a pill we have in Sweden that have a little bit of each amino acid. So, you know, this is not rocket science to do. It's pretty simple, but you need to know how to check for deficiencies and put it together, because of course it's different for each client, you know, what they need or don't need. But it's simple to learn.
Can I ask you about glutamine? Did you use glutamine for the detox at the beginning?
I use glutamine and coconut oil or MCT oil as a snack between meals. That is not part of this, but that's always something I use all the time. Yeah. So look at her fatty acid profile 1 year later. You know, more beautiful on that, you can't have it. Green, green, green. Very nice. So she's keep doing a good job, this young lady. Another thing I do is this little toy. I don't know if you had time to look at this before, but I do tell all my clients from day one when I recommend any type of recovery tools to start with this. I used to sleep tape, you know. I asked them to send for the book, and you have it in English there, and read the book, because this is the best science in the simplest, most easy way I've read about breathing ever. There's a lot of, you know, mindfulness and breathing techniques and yoga and, you know, Ashtanga and all those kind of things. But my experience is that people in the beginning of recovery are so overwhelmed with everything. So it has to be the simplest simple of all. And this one is. So not everyone can read the book. And then I just teach, because they can't concentrate. So I just teach them what to do. You know, how to do the simple 3, 6, 3 breathing once they are walking or when they drive the car or whatever. And this is a relaxator that promotes abdominal breathing. Mouth breathing causes oxygen depletion, apnea, and stress. And anyone that is stressed will breathe with their mouth. Or if they snore, just tape their mouth at night. Some people think this feels horrible to put a tape over your mouth when you sleep. But once you get them to try it, they have a much better sleep and they are much more energetic when they wake up in the morning. So this is one of my absolute favorite tools to use on the clients.
Can you give?
Oh, I'm sorry.
Sorry.
Breathing.
Can I ask a question a bit about the? I get a lot of people that have sleep disturbances. I think it's called sleep apnea, and that the ones that need to use the, you know, the thing. And so, do you feel that this? I know that a lot of those people, once they get abstinent, you know, that in itself just helps a lot. So do you see that this kind of, you know, comes instead of using the machine? Or
most people can get off asthma medicine and the breathing machine if they start being abstinent and use these tools. And if you go to his website, you know, consciousbreathing.com, there is so many cases telling there, you know, they have had panic anxiety for 10 years and they start using this breathing technique, taping, relaxator, and training, you know, and the anxiety just disappears like crazy. So there's a lot of research, a lot of interesting things to read there. And please read the book about metabolism, because our body's way of detoxing is, you know, if you breathe proper, you help it is 60% of the natural detox cleansing of the body, you know, the rest products is breathing. Perspiration is only 30%, and going to the loo and doing number 2 is only 10%. And people, you know, all they talk about is having to go to the bathroom. They forget about breathing, which is the most important of all. So I do recommend that you look into this. And you also have in your material, you have a link to what happened to me when I discovered this technique. The thing I love about it is that, you know, he talks about overbreathing, and that's what people on sugar and carbs do. They go, they overbreathe. So we need to teach them to slow down and, you know, and only breathe with your nose, not with your mouth. And a lot of people have stress apnea, You know, you come to your computer, you open the computer, and it's 40 mails, and you go, you hold your breath. You're stressed in any way, you hold your breath. And that is very bad for you. Okay, we need to keep along. Oxytocin, which is the body's biggest relaxation, calm down hormone. And of course, you know, there's a lot of research done on adrenaline, noradrenaline, your flight and fight hormones, but the natural relaxation hormone is not so much research done on. But I happen to know one of the world's leading researchers on that. And I had many discussions with her about oxytocin's role in food addiction and especially volume eating. You know, there's a lot of things that could, you could be born with not enough. You didn't have enough bonding when you were a kid to develop this. You were stressed, you ate junk food early, blah, blah, blah. There are many, many reasons. Your intestinal flora was broken. Your body is not capable of creating enough oxytocin and so forth. So if you look at optimal levels, you see some interesting thing that a person is then trusting, open-minded, curious, interested, kind, sensitive, have a low activity in heart and vascular system, which is very good for us, and high activity in digestion and nutrient uptake. Wow, that's excellent. That's what we need. You feel relaxed, contemplative, and easily satisfied, you know. It's cool, it's nice, I'm fine, you know, okay. And you have a natural feeling of being social and serene, and natural self-healing ability is heightened. But if we have low levels of oxytocin, we tend to be irritated, stressed, tensed, scattered mind, sleep disturbances, cravings, and usually, you know, it's a kind of cravings, oh, I don't know what I want something, oh, I'm bored, I want something. It could be that you just try a lot of different things because you really don't know what you want. You're easily bored, you're feeling lonely even with others, and having a hard ability to bond, you know, nobody likes me, I'm different, you've certainly heard that, all of you. And it is that person that actually is blocking other people to come to them. Feeling of uneasy, competes, want to achieve, and volume eating. And many years ago, I read her books and her research, and I called her and asked her, you know, is there any amino acid I could use to heighten oxytocin in these people that I see have this? And she said, no, we can do it with oxytocin, but we don't have an oxytocin yet that you could take orally. So we don't have, you know, a pill or a powder or anything that we could use readily to help these patients in the beginning. But she said, and I told her how it works, she said, if you balance dopamine, serotonin, endorphin, you will automatically increase oxytocin. And I think that's very hopeful. That's wonderful. So that's another reason to do this. And if you look at her research, how you raise oxytocin, since you can't do it with amino acids then, optimal nutrition, protein and fats are very important for the body's, and of course your intestinal flora, and you know, so your body's breaking it down and taking it up into your body. And here it is slow physical activity, you know, not, you know, running like a madman. And that's good for your heart and lungs. But if you want to raise oxytocin, I used to joke and say to my clients, take a walk in the woods and count the leaves on a tree. That's a good practice, you know, for these. Any type of yoga, meditation, of course, breathing exercise, crafting, garden work, you know, whatever you like. Tactile massage, pedicure, hugs, massage, going to the hairdresser. Serenity, rest, prayer, spirituality, and pets, especially dogs, they say. They interact more than cats, but I think cats is very important too. And actually, they wrote a book that's called Attachment to Pets, which I love, since I'm a dog lover, of course. But that's very interesting. So there are ways that we can increase oxytocin without having to take something. That's good. Okay, so when I work with a client, I do a lot of tests. I told you about at least nine different tests. I check all these things. I usually don't take a lot of blood works because, blood work to me doesn't really say a lot. Blood work could be good once you are really having your head under your arm, I need to go there. But in the beginning, when you're just very unbalanced, you can't see any damage on your liver or damage on your kidneys or, damage on your blood or anything like that. So usually my clients have gone to the doctor's office many, many, many times, and they are so frustrated because they feel really sick. And every time they take the blood test, they come back to the doctor and said, no, it's nothing wrong with you. Everything is fine. I'm sure you've heard that. So that's why I do the integrative functional medicine tests instead. I think, they are much more valuable because they all are several pieces that I put together to a picture about, how the patient, what needs to be addressed. What do I need to start working with first, And of course, that's always the food and the breathing and the sleeping, the natural healing, like halt the abilities. Okay. So one blood test I like to take, and that's because I read James Braley and Patrick Holford, it's homocysteine. Because homocysteine, usually they say in Sweden that it should be 12 to 15, that's normal. But these people, Patrick Holford and Jim Braley, in the book The H Factor, they say in addicts it should be 4 to 7 because we need to have the best methylation process going. And methylation, that is the body's ability to make neuronutrients from what we eat. That's methylation. So homocysteine, I think, is important. Not everyone can take it, but if I have a client that can take it, I do. I always do. So, and then I work with different methods to lower the numbers if they are high. So these are some of the things I do then. Well, we don't have too much time, but I think, as I think it was Sherry that asked me a question where I said, we can't, everyone cannot be, 100% good at every piece because addiction is so complicated. It's such a complicated and difficult chronic illness to treat, rest of our lives. And I think that's why we need to work as multidisciplinary team. Like when I'm with Esther, I learn a lot from Esther that I don't know about. And also, there are certain pieces in this holistic treatment that doesn't make me drool, It's just not really interesting to me. And then there are other pieces in working with addicts that really makes me excited and enthusiastic and, oh, this is what I like to work with and this is interesting for me. And then I know other pieces somebody else had. So we need to combine. And I think this school is also the first time where we really address, in a holistic approach. We don't just talk about psychotherapy or just talk about 12-step or just talk about, supplements or anything. We really look at the whole picture. And I love that. So my favorite is to work as a multidisciplinary team. And I've always worked alone, but in a multidisciplinary team. Because I've had, all kinds of different specialists around me that I can talk to and send the clients to and so forth. Because I can't do it all. And I'm not interested in all. That's another thing. So here are some of the things I think is very very important in modern treatment, like, you know, screening, assessment, and diagnostic, and that we are aware that this is a lifelong illness and that we need to help our clients to restore energy fast so they can really start develop the new recovery tools. You know, they can start use new connections, brain bypass in the prefrontal cortex, in the limbic system, and in the neocortex, because they have lived their life from the reptilian brain, and that's no fun. So they need brain education and addiction education and neuronutrient therapy and 12-step, you know, about powerless meal plan, craving, relapse prevention, relapse treatment, sponsor, coach, planning, replanning, step 2 and 3, and so forth. Stress management, and different kind of therapy. Everybody, you know, once people are coming out of the fog, you know, you can start see that some might need therapy for incest, another one needs therapy for some type of trauma, and everybody needs to work on developing themselves, but we don't know that in the beginning. So we take one step at a time, as the program teaches us, which is difficult when you're like me, want to do everything at once. And I also think that the traditional healthcare system needs a lot of education about the 12-step programs and their advantages. And I cannot for my life understand why people are so resistant in Sweden towards that. It's very inexpensive. It's the wounded healer, the layman. It's very efficient. There is no rules, only suggestions and principles. Well, you all know this. Available 24/7 and sponsorship. And then I just did a short thing, a new vision for treating food addiction, or actually it should say addiction, that it should be based on medical care. And with that, I mean that it has to be some kind of medical knowledge, since it is an illness. It is a very complicated brain illness. So I used to say that counselors that should work with this need to know where the kidneys are. That's my opinion. Not everyone needs a medical degree, but you need to be aware of that. We should focus on salutogenesis instead of pathology, which basically means that we, from the beginning, start giving the clients health factors. You know, do this instead of, oh, you shouldn't do this, and that's so sick, and God, you're so sick, and it's not really helping anyone. We help them see choices. Why don't you try this? Why don't you start doing this? Focus on the healthy part of life, because it's a brain disease, and that we have a holistic view, and it's multifactorial disease, genes, environment, drug. We need a multidisciplinary team. We need to transform motivation from outside the client to inside the client. They might come because I feel horrible. I have 50 kilos overweight. I feel so ugly and fat and disgusting. But if we cannot get them to understand they have a brain disease, you know, and start working in lifelong program, if all they think about is lose weight, we're going to lose them. We're going to lose them. We all know that. That is not enough. So knowledge is not enough. We need to give our clients understanding and help them change attitude. And we need to educate them versus training them. And now I'm done. Whew.
Thank you.
Thank you. I'm sorry I kept you half an hour longer, but you know.
I'm pretty sure everybody is happy about that. Would you take a few questions?
Absolutely. Absolutely.
Can I ask something?
Sure.
Yeah.
Going back to the glutamine, can you give some details of normally the doses when you start with someone who has very strong like flour addiction, like in this case, the case of the girl?
You're speaking too fast, Maria. Please slow down and take it more simple.
I'm sorry. Can you give details of how you apply the glutamine, the doses, and during the day, and for how long normally? In the case of that girl.
Well, I take it flour right away, and I start with 1 teaspoon between meals 4 times a day, and then I increase so that they usually have 3 to 4 tablespoons in a half a glass of, you know, table water, not warm water. and 1 tablespoon of coconut oil 3 to 4 times a day between meals.
And together always, or not necessarily?
No, it doesn't have to be together all the time, but usually I do it together, yes. Okay.
Thanks.
Anyone else have a question?
I have a question. How would you define biochemical repair? Like, how would you simply define?
Well, yeah, I wrote a paper that I put in Dropbox, and I read it for you because you have a paper to read later. The purpose with biochemical repair, it is to restore the body with natural things, you know. It's no strange pills or anything. And you have the definition of orthomolecular medicine and integrative functional medicine, which means that you give the client things that they lack, you know, in the methylation chain, which you of course look for first, what could be that. But you restore their energy physically, psychologically, socially, and spiritually, so that they faster can adhere to the food plan, start going to meetings, start reading literature. So, you know, all this kind of stuff with your burnout or foggy brain disappear. It should go away faster. So you get them back to feeling well, restore sleep, you know, breathing, you know, so all those things you address. And you just restore them. It's actually restoring. It's nothing weird you add from the outside. Is that answering your question?
Thank you.
Okay. Yeah? Anyone else?
Yes. If nobody else, I mean, unless there's someone else. Okay. Are all your treatments Bitten?
Please hold it further away. Hold your microphone a little bit further away. Okay. What was the question?
Now, can you hear? The approach that you have.
We can't really hear you. I'm sorry. We can't really hear you.
I can't hear you. It's so much echo and noise around.
The mic is too close to your mouth. Just let it drop.
Maybe now, like this.
Better.
Okay, it's okay. Thank you. It's in Sweden, Bitten, where you treat the patients. It's mainly outpatient treatment.
We only have outpatient. We have no in-house patient. We have one treatment center for alcoholics, pill addicts, and drug addicts that can take a few clients now and then, but most people never get money to go there. So 99.9% of all the clients I work with is outpatient, you know. Yeah. Okay. And it works beautiful. You can do it outpatient.
Bitten, how do we contact you if we want to?
You mail me. I'm on the mailing list. You're so free. Please mail me if you want and have questions.
Bitten, another question that I would like to ask. Regarding this principle of the between 4 or 5 ingredients, if there's any word that's akin to sugar or flour or starch, do you allow it or not? How do you consider that? Or you just remove any kind of not fresh?
No, we can't hear you.
It's such echo and ringing. Could you mail me that question, Maria? Could you please mail me the question?
Okay.
I don't know why it is not working.
And it's Bitten.Jonsson with 2 S's at bittensaddiction.com for Bitten.
Maria has my address.
Yeah.
And you're very welcome to mail me. And I can Skype with you if you want, you know. Give me a mail and we set up a time and I can Skype with you if you have questions. I'd be happy to share anything, you know, I've done about this because I love working with it. I really do. And it works.
And how long does it take to do that first assessment with the ADIS and the sugar?
Well, it takes some hours, but you know, many of the instruments, I mail them to the client ahead of time, and they, you know, save them in the computer and open one, and then they fill it in, and then they mail it back, so that I have a system for the mail summary back. They don't mail each instrument back. It says very clearly on my mail to the client when they want to do this, how they should mail things back to me. And then some they send back as they are. And then I have a schedule, an appointment, usually on Skype or telephone if they want. And then I do a deep interview where I ask a lot of questions from, I go through the material they send me. And of course, you know, with my trained eye now, I can see a lot of things going on. And then I have an interview with them on the phone, which takes, you know, at least an hour, sometimes two. And I ask them many, many more questions to piece the puzzle together. And then I sit down and it takes me maybe another hour to do the treatment plan, the first treatment plan. And I send that to the client. And then they have to mail me that they understand what I've written and that they agree. And then they start on the treatment plan. And I work that the food and supplement part should be 10% of the whole treatment plan. Working with relapse prevention, thoughts, urges, feelings, you know, is 40%. And 50% of the treatment plan is for them to start joining 12-step meetings or support groups. So they don't only focus on food and pills, you know, which of course they like to do that. But, you know, I emphasize that that is not going to help them. And then they start, and then I do updates once a month on their Skype, you know, and then they fill in, not everything from the beginning, but they fill in a few forms that, and that could be individual depending on what's going on. But, you know, I want you to fill in about your thyroid. I want you to fill in about your intestinal flora or blah, 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 blah. And then send that back to me. And then we have updates about once a month in the beginning till I see that they are, you know, going well in the recovery. And then I can do every other month or every third month. It depends on, you know, what they can afford in treatment too, and, you know, how motivated they are and so forth. But I can see that the ones that I get to work with for 6 to 18 months, they are really well off. I mean, they are doing a much better recovery than the ones that don't do this at all. So there is a difference.
Can I ask oh, I'm sorry, Mary, you go ahead first.
How much do you charge for that assessment? Because that's hard for the patient to see the value they're getting, I bet.
Absolutely. I charge in Swedish crowns. I take 1,250 plus taxes, which is 25% in Sweden, for the first, you know, 2 assessments, you know, doing everything, doing the treatment plan and having the first update. And then I take 1,000 crowns for every full hour I do the update. So if I only do half an hour for 1 month, you know, I take 500. And then of course, you know, you have to see too that they can have money for, some can't afford all the supplements that I like to give them, because supplements cost a lot of money in Sweden. So I have to be very creative, you know, which supplements is important for these clients. And if they say, well, you know, I can't afford any, food is always number one. I want them to, you know, have money to learn how to eat good food and cook proper food. So then I say, well, you know, stick with the food. And then we could add on something maybe later. So it's very individual.
And I was wondering,
I just checked how much it is in US dollars. It's about $138, $40 for the initial 2 sessions.
Is that a lot or is that a little?
Very little.
Oh, okay. Well,
Yeah.
that's what we can do in Sweden.
Wow. And is
Because
it
it's only private pay, so if it would be within a clinic setting, we could probably take more, but.
wow.
And I have a question, you know, especially with my background being a trained psychologist, I'm obviously thinking about the mental health side of it. So I'm wondering how often in your treatment plan people are referred out for those kind of services with mood disorders, mental health issues, or trauma.
Well, you know, I only work with intensive care. So I only work with my clients for about 6 to 18 months. So, you know, usually when we work, you know, usually it's hard to say, but, you know, it's after that time that they usually themselves look further for, you know, psychological help or mental health disorders. But actually not a lot. Very few.
Mm-hmm.
Very few. If you work with them like this.
Mm-hmm.
Mm. So I don't mean to take away your job, Kathy. I'm joking. I'm not going to be out of job. Yeah.
You know, there's a lot of research out now with the ACE about childhood adverse incidences, and the more incidences they have, the more likely they are to be addicted. And then I think about the big book saying, you know, alcohol's but a symptom, you get down to causes and conditions. So, you know, I'm just thinking about that aspect of it, you know, how that would be tailored to make treatment, you know, more efficacious, I guess. Yeah.
Yeah, well, absolutely. We need to be much more aware of diagnostic and screening in that part. Definitely. You know, the problem here is that people like you, they don't understand addiction. So they do not put any emphasis on taking away the drug and stick to being drug-free. That because rather they say, well, you should be able to eat a little bit, or, you know, drink a little bit, or we have this, and I wrote that in the paper that I sent out in Dropbox, that the new thing in Sweden is to teach alcoholics to drink social. Yep. And they rather, and then they, you know, talk about treating trauma instead. And that's what I'm against. I'm trained in US that, you know, you deal with the drug addiction first and then you deal with the trauma, not the other way around.
Mm-hmm. And this I see is the major thing that, you know, kind of what I see with professionals in the obesity field. Now they're really understanding the trauma part of it, and they want to fix that, you know, that mommy had a square nipple or things like that before they do anything else. And because
they want to fix that with SSRI pills.
Yeah, right.
It's not going to work.
Okay, so I think we should really say thank you to Bitten at this point, and thank you for your, you know, grace and your gracious giving us the extra time. I really appreciate it, and I know everybody else probably does also, and also that you graciously are willing to take individual questions. And I just wanted to say that, like, some people have been sending me questions. I would really like to, when you do that, to have, you know, let me answer them in a way so that I can both show the questions and the answers to everybody else. Because if one person has a question about something, it's usually something that everybody would like to know anyway. So you think about that, you guys, and when you send questions, you know, you may not want me to publish that, but if you do, I'd really appreciate sending out answers to questions that come in to the best of my ability, and I'm sure Bitten would also. Okay.
I'll be happy to share. Thank you very much for taking the time to listen to me.
Thank you, Bitten, and we'll talk soon. We'll talk soon, and for everybody else, we're gonna thank you, Bitten. For everybody else, we're gonna take 5 and then come back and finish with the council workbook, with the material on assessment and screening, and we're gonna start talking about treatment plans somewhat also. Okay.